the privilege to introduce Dr. Anita Chopra. Dr. Chopra is an internist and faculty at University of Washington School of Medicine. She's a lead physician at the UW Long COVID Clinic. She also is a co-investigator for the AHRQ Long COVID UW grant and chairs the ACP Long COVID Interest Group. You will hear about that a little bit from her. It's a great way to connect and get informed. She hosts it once a month on Wednesday. You'll hear about that more in the talk. Dr. Chopra also co-chairs the Washington ACP Primary and International Medicine IMG Graduate Councils. She also is a director of Northwest Health and Wellness. She has received many ACP awards, and just yesterday she received the ACP Laureate Award. So welcome, Dr. Chopra.
Thank you so much, Prachi. It's such an honor to be here. And I want to start off by thanking Prachi and Doug for an amazing job chairing this meeting. And also, as always, Chris Knight for his leadership. Thank you very, very much. I'm Anita Chopra. I am one of the lead physicians at the University of Washington Long COVID Clinic. I am so honored to present the Long COVID talk today. I will be talking about long COVID, forging the path ahead, and the focus will be on primary care physicians. I will touch briefly on two very important phenotypes of long COVID, which are chronic fatigue and dysautonomia, but I would like to share a perspective from the primary care lens. I also want to acknowledge Maureen Lyons from the Oregon Health and Science University, who was supposed to co-present with me, but she could not make it today. Thank you, Maureen, and I miss you today. I would start off by acknowledging two very important people and two leaders in long COVID care, Tiffany Walker, director of the Long COVID Clinic at Emory Health System in Atlanta, and Jana Friedli, the executive director of the Long COVID Cares Clinic at UW Medicine. Here is a quote from someone who lives with infection-associated chronic condition. It's Megan O'Rourke, and she says, in an age when medicine is based on evidence, what can be done for people who live at the edge of medical knowledge? I think this is very significant. Megan is a writer and poet from Yale University. She lives with IACC, which is infection-associated chronic conditions. This really defines the state that long COVID patients live in. And it is for us physicians a call for action. Recently, NASM, the National Academies of Science, Engineering, and Medicine, came out with the 2024 long COVID definition. They define long COVID as an infection-associated chronic condition that occurs after SARS-CoV-2 infection and is present for at least 3 months as a continuous relapsing and remitting or progressive disease state that affects one or more organ systems. You will notice that there is no mention of a lab test for definition. So this is now universally adopted as the official definition for long COVID. So in our clinics, we will see patients who present one day as doing their activities of daily living as normal, and the next day they cannot get out of bed. So that is what is relapsing and remitting, a pattern that we see in other conditions like multiple sclerosis. This slide really shows the common phenotypes of long COVID. And towards the right, I want to show you, or towards the left, sorry, your left, post-exertional malaise as one of the common phenotypes. It's a hallmark symptom, which I would call as triggered fatigue. Triggered fatigue and what are the triggers? The triggers can be physical triggers, including overexertion, presenting either as an immediate effect, debilitating fatigue, or delayed fatigue, which could present after 12 to 72 hours. Emotional stress, cognitive burden, or environmental burden, including difficulty concentrating. People can have memory changes, lightheadedness, sleep disturbances, problems with taste and smell. The other common phenotype is POTS, postural orthostatic tachycardia syndrome, as an umbrella term, with dysautonomia as hallmark of this presentation. Now, ME/CFS, which is chronic fatigue syndrome, and dysautonomia have several overlapping mechanisms and presentations. Long COVID can be serious, and who is at risk for long COVID? We see and CDC defines that anyone can get long COVID, but some people are at higher risk than others, and those populations are African American populations, Hispanic populations, people who had severe disease initially and were hospitalized. Although I would go on to comment that most cases of long COVID are people who had mild or asymptomatic disease, women and unvaccinated people. Now, what is the prevalence of long COVID? So we see studies have shown, and CDC states, that 7% of the US population has long COVID, which means 20 million Americans between the ages, especially of 30 to 50, have long COVID. So you can imagine the significant disease burden, the disability burden, and the economic burden as well. So here are some of the goals for this talk today. I hope that we can formulate a plan or have an understanding of a plan for integrating long COVID care into primary care practice. My focus today is primary care physicians like myself who find this to be a challenging condition. Understand patient perspectives, which is so very important to improve the diagnosis and management of long COVID, and identify and use resources available for long COVID care. I really hope, as a primary care physician myself, to highlight these available resources and to make long COVID care less daunting than it appears. I'm presenting this case, which is just to set the stage, and many of you have probably seen this presentation in your clinic. A 45-year-old woman with some comorbidities, diabetes, had history of COVID approximately a year ago. The initial infection was mild, congestion, sneezing, diarrhea, headache, fatigue for 3 days. Initially improved to baseline, but then the constellation of symptoms developed a month later. So imagine that she was doing fine for a month, and then a month later, she has these symptoms, now with 9 months of fatigue, myalgia, worse after exertion. Tachycardia, heart rate, inexplicably goes up to 130s when walking to the kitchen. Shortness of breath, a buzzing sensation, brain fog, which is a term that patients will use very often, and brain fog can mean memory changes, can mean word finding difficulty, can mean problems with attention and focus. All of this is brain fog for patients. And new food sensitivities. Unable to work full-time due to symptoms, concerned about finances, feels anxious, worried she will never recover, and mentions the previous clinicians did not believe her symptoms were real. So I really want, as primary care physicians, for us to focus on that last sentence, where we are dismissing some of these patients, and we hear this a lot in the long COVID clinic. I cramped up a lot of the phenotypes in this one case, just to show you a picture of what people might present with. And not everyone will of course have this kind of a picture. I want to highlight one important thing that I mentioned in this case, which is post-exertional crash. So we notice a typical push crash kind of picture where patients will push themselves one day moving heavy boxes or trying to get exercise done, and then they cannot get up from the bed for the next few days, which is a hallmark of ME/CFS. So this slide shows the constellation of symptoms. They appear in clusters. We have neurological clusters, we have cardiovascular clusters, we have ME/CFS, and dysautonomia clusters. But as you can see, there are more than 200 phenotypes which have been described for long COVID. I really like this slide because this really gives you a sense of the pathophysiology of long COVID, what is going on. And there are different hypotheses which have been presented, but I want to highlight some of them just for our understanding. And the very first one is viral persistent state. So some form of immune dysregulation with viral persistence or even reactivation. For example, reactivation of the EBV virus or HHV6 virus. Persistence viral antigen can cause immune responses. Spike antigen-specific T cells have been seen, which point to a viral persistent reservoir. The next thing is microbiota dysbiosis. We see that a lot. The impacts of SARS-CoV-2 on the microbiome, including the SARS-CoV-2 persistence, causes changes in the gut flora and also impacts immunological responses. So this is one of the mechanisms of long COVID. The third one is autoimmunity and immune priming. We see alterations in memory B cells and signs of reactivity. So autoimmune conditions can either be triggered or worsened. In my clinic, I have had the misfortune of seeing new diagnosis of rheumatoid arthritis, autoimmune thyroiditis, type 1 diabetes in patients after they developed COVID. The next major mechanism is blood clotting and endothelial abnormalities. Microvascular blood clotting with endothelial dysfunction is one mechanism. And the last one here is dysfunctional neurological signaling in the brainstem. We see autonomic neuropathy. We see activation of glial cells. And one thing that's not mentioned on this slide is there was a recently published study which talked about mitochondrial dysfunction, impaired oxygen extraction from peripheral muscles, and signs of muscle necrosis, which can in turn impact chronic fatigue. I also really like this slide because this talks about serotonin reduction in long COVID patients, and this has been published. This study published in the journal Cell, it talks about reduced tryptophan uptake in the gut, reduced serotonin levels in patients, which in turn causes neurocognitive defects. This is so very relevant for us primary care physicians because this can impact our care. And this also highlights why SSRIs may be helping these patients. So we have had some dramatic results with SSRIs in patients reporting benefit not only for their psychiatric symptoms, but also for brain fog and neurocognitive disorders. A new paradigm is needed to explain long COVID, and this slide talks about the interplay between triggers for patients, the biological factors, and psychological factors, in addition to social factors, how they come along and create this picture of long COVID. The biological factors include, of course, ongoing immune changes, viral persistence, the chronic inflammation that happens. There's deconditioning, there is dysautonomia, there are sleep disturbances and psychological disturbances. The emotional burden and emotional impact of long COVID are the psychological factors or the experiential factors that patients experience. And then, of course, the triggers, which can be physical, emotional, cognitive triggers. Here at the University of Washington Long COVID Clinic, as well as the other AHRQ sites, our goal is to provide patient-centered and integrated care. Long COVID, we recognize, has a major impact on overall health and well-being. Behavioral health triage and support is very important. Awareness of ethnic and racial differences in outcomes may inform clinical decision-making and aid in advancing health equity. If available, we work with panel navigators. They are very crucial to support clinicians and patients. We do have panel navigator in our clinic at the University of Washington. Extended visits are important, and it's important for primary care physicians to know that, we, especially as internists, we have 20 and 40-minute visits, and these may not be sufficient for these patients. All patients need time to recover, and a very, very important thing in their care is relapses are very common. Relapses can happen if they have stressors, or if they get COVID again, or any other illness. Putting it all together, the considerations of care for primary care physicians are, number one, awareness of this entity, awareness of this beast, long COVID, understanding what resources are available, developing or partaking in educational resources and activities around long COVID, and how can we respond to patients. The patient treatment goals need to be met, and we cannot do this without the partnership of primary care physicians. We do offer multidisciplinary care at the long COVID clinic, not only at University of Washington, but other national sites as well. But I think the main person providing that care has to be the primary care physician. So how do we find the delicate balance? The first thing is, as PCPs, to validate symptoms, approach the care holistically, which I will talk in a little bit, and learn together. We are all learning together. We do acknowledge that we obviously don't know everything. We know where we have just scratched the surface. There's a lot that we don't know, we are finding out. We have to evaluate patients for common overlapping diagnoses, but practice strong clinician stewardship with patient-centered referrals and lab test utilization. Reframe from needing to find a definitive answer to moving forward and managing the symptoms as a team, and gain comfort with the discomfort of making the official diagnosis of long COVID. I know we are all very hesitant to make that diagnosis, but hopefully we'll get a little perspective, from especially my own admissions as a primary care physician, now specializing in long COVID, that we are all very hesitant in making that diagnosis. So here's a slide talking about diagnostic criteria, and you will notice again that there is no single lab test which is talking about that. Continuation or development of new symptoms 12 weeks after SARS-CoV-2 infection, suspected, probable, or confirmed SARS-CoV-2 infection as defined by the Pan American Health Organization and now NASM. Suspected case of SARS-CoV-2 infection, a person who meets either the clinical or epidemiological criteria, B, severe respiratory infection with typical symptoms who requires hospitalization, or with no clinical signs and symptoms, nor meeting epidemiological criteria, but had SARS-CoV-2 infection. Number two is probable case of SARS-CoV-2 infection, someone who meets clinical criteria and epidemiological criteria. And third is, of course, a confirmed case of SARS-CoV-2 where we did the lab test. So you will notice that there's no single thing telling us this patient has long COVID. Can long COVID be treated? There's no universal treatment either. So I don't know why I'm standing here. There's no lab test, there's no universal treatment, so why am I even here? So patients may present very differently, so treatment must be tailored. And the three important pillars are cognitive, managing their cognitive symptoms, psychosocial symptoms, and physical symptoms. It's a rapidly evolving field, so I do want to highlight resources available. And what we are working on right now for primary care physicians in the long COVID clinic is to come up with a clinic patient education handbook. So long COVID holistic treatment approach, so not one good treatment, but multiple things coming together, include tailored restorative exercise, Sleep, restorative sleep, improving the quality of sleep also includes several patients who are newly diagnosed with sleep apnea now and have to be on CPAP. Mental health, including managing their anxiety and depression. I want to make a shout out to our rehab psychologists who have pioneered the development of group visits for long COVID patients, and patients really benefit from those group visits, as well as nutrition. I'm not going to go deeper into this slide, but I want to just highlight some of the clinical trials going on in the long COVID sphere. You can, of course, they are available on clinicaltrials.gov. Amongst them, you will see that UW is also hosting some of these Paxlovid, prolonged Paxlovid treatment to help with the long COVID. There's Recover Neuro, which measures the effect of therapies on long COVID neurocognitive dysfunction through the neurocognitive rehabilitation. Recover Auto, which is looking at the therapies on long COVID autonomic dysfunction, including ivabradine and IVIG. Recover Sleep, which is, of course, working on long COVID sleep symptoms and utilizing modafinil and I cannot even pronounce it, salmeterol. And of course, we are hosting Recover Energize at University of Washington. We are looking at the effects of cardiopulmonary rehab on long COVID symptoms, which include cardiopulmonary rehabilitation services. This slide talks about timeline of long COVID recovery. And this shows that persistence of symptoms at 4 weeks and 12 weeks. And we see this at a higher rate in women. So most recoveries of COVID, acute COVID, they occur within the first month. But if they are persistent beyond 3 months, then we see long COVID come in and a slower rate of recovery. This slide also shows a similar picture, but talks about milder symptoms in acute COVID, but causing persistence of long COVID over longer period of time, even beyond 7 or 9 months. I want to highlight here the role of the PM&R guidelines, consensus guidelines, which came out over a period of 2 years and are now essentially the Bible for treating long COVID patients. These are evidence-based guidelines, very comprehensive guidelines, which are breaking down long COVID into individual clusters and individual symptoms and giving primary care physicians and rehab physicians guidelines on how to manage each of these conditions. They are multidisciplinary, collaborative consensus guidelines. And actually, in the next few months, we are getting a compendium to these guidelines as well. So please keep a watch out for those. These are the AAPM&R. This is the website which breaks down these guidelines into mental health, autonomic dysfunction, cardiovascular, and much more. And these are really, really helpful for primary care physicians like us. This slide is actually very important, and I encourage you to take a picture of this slide. And there are no FDA-approved long COVID treatments available, but these are, I'm highlighting repurposed drugs we have used based on anecdotal or observational data and small trials. So these are our different AHRQ sites, teams coming together and pooling in their resources and seeing what has been helpful. One of the things that I really want to highlight here is low-dose naltrexone. I know that a lot of you, like me, have questions about this medicine that we are magically using in the long COVID clinic. It's called LDN. Low-dose naltrexone has been shown to be of benefit in patients with long COVID and persisting, especially chronic fatigue and myalgias. It has anti-inflammatory and immunomodulatory properties, and especially benefits the long COVID patients because they have persistent inflammation. Not all long COVID patients will benefit from LDN, but some of them do. We do not have any randomized controlled trials yet, but we do have some observational studies, especially coming out of our partners at Stanford. And LDN, we start at a low dose of 1 milligram. We go up to 6 milligram per day. It's a compounded medication. And for some patients, this can be life-saving. Now I want to touch upon the phenotypes which we see very commonly. And again, it's not a comprehensive review, but I do want to highlight autonomic symptom burden in long COVID patients, which manifests as dysautonomia, but also as MECFS. MECFS and dysautonomia share similar mechanistic and phenotypical characteristics. And here is the umbrella of dysautonomia, which includes under it several overlapping features of MECFS and dysautonomia. This can present as a constellation of symptoms, and you will often have patients coming into clinic and saying, I have POTS. And they will make this blanket statement, and I see POTS mentioned in their problem list. Automatically, it will enter into their problem list. And I really want to make sure that I give you this message to deter you from using that word POTS, because sometimes we just use it very lightly and we have not substantiated it. What it is actually dysautonomia, the umbrella. The triggers include prolonged standing, warm environments, upright exercise, large meals, some medications, and alcohol. And the symptoms include orthostatic presyncope, tachycardia, palpitations, chest pain, shortness of breath, but also unexpectedly for PCPs, GI symptoms, including constipation, diarrhea, gastroparesis, nausea, vomiting. So in these cases, as PCPs, we need to exclude, of course, other disorders which are more common: anemia, thyroid disorders, medication effects, and adrenal insufficiency. But then we move on to this, which is measuring orthostatic vitals, which is easily done in the office, can be sufficient. NASA lean test is something that we do in the long COVID clinic, measuring vital signs with standing with feet 20 centimeters from the wall and recording the vitals over 10 minutes. It's more sensitive, but it is more time consuming. Just because we are cognizant of this, we are doing it, but a lot of you PCPs do not have the time or bandwidth to do this in the office. And then, of course, the gold standard test is the tilt table test, only done at our specialist's office. This slide shows the NASA lean test. This is just the form, the standard form that we fill out, which talks about how to do it, what to record. There are certain medications that need to be stopped before we do it. And this slide, I borrowed it from the Bateman Home Center, which is, again, like a powerful resource for us primary care physicians. So this slide just gives an overview of some of the changes, the differences between POTS and orthostatic hypotension and vasovagal syncope. With POTS, the blood pressure is not dipping, the heart rate is rising up, but you do have orthostatic symptoms. However, in orthostatic hypotension, the blood pressure dips and the heart rate goes up. Diagnostic criteria for POTS: sustained heart rate more than 30 beats per minute in adults, more than 40 in adolescents within the first 10 minutes of standing in the absence of orthostatic hypotension, frequent orthostatic symptoms during standing with rapid improvement on recumbency, and duration of symptoms for at least 3 months in the absence of other symptoms that I talk about here. So this is my word of caution, labeling people with POTS in long COVID, and we enter the downward spiral of decreasing activity. They develop that mindset, deconditioning, and worsening symptoms. What we see in long COVID patients is that the heart rate and blood pressure fluctuations, they improve over time, and actually they are the first to improve amongst all other long COVID symptoms. So how do we manage orthostatic tachycardia? we start off by withdrawing any culprits, any medications that can be culprits, hydrating the patients well, increasing salt intake and compression stockings. And if we do need to bring in medications, the commonly prescribed medications are in tachycardia predominance, we use propranolol. If low blood pressure is predominant, we use midodrine, and we can also use fludrocortisone, although I find that fludrocortisone is mostly started either by the neurologists or the cardiologists. This is my other common phenotype, which is the ME/CFS. And the proposed diagnostic criteria for ME/CFS are a substantial reduction or impairment in the ability to engage in pre-illness levels of occupational, educational, social, or personal activities that persist more than 6 months, and is accompanied by fatigue, which is profound. It is of new or definite onset. It has not been there lifelong, and is not the result of excessive exertion. It is not substantially alleviated by rest, and post-exertional malaise, and unrefreshing sleep, and at least one of the following: cognitive impairment or orthostatic intolerance. So I just want to highlight that chronic fatigue can also manifest as cognitive fatigue. So patients will come to us, I push myself and I crash, I push myself and I also get brain fog. So both of them are interlinked. So if they are coming to us with brain fog, we have to sometimes tease out the fatigue. So the important thing is to remember is the pre-illness levels of their activity. And again, this slide is highlighting post-exertional malaise, which is the triggered fatigue that I talked about earlier. The important things to remember are post, which could be often delayed. It does not happen immediately after they are moving boxes, can happen after a few days. Exertion, which could be physical, cognitive, or emotional. And of course, malaise are the symptoms. The post-exertional malaise is unique to ME/CFS and long COVID. It is pathognomic to ME/CFS. At the bottom of the slide, I talk about the DePaul symptom questionnaire, which is DSQ, for post-exertional malaise. And there are some diagnostic criteria, which mostly our rehab physicians use, but it's important for primary care physicians to know that there does exist a questionnaire, which is the DePaul symptom questionnaire. Long COVID fatigue. These are the 4 pillars on how we manage long COVID fatigue. The number 1 is pacing. Pacing means conserving energy, avoiding the push-crash cycle in post-COVID recovery. So we advise patients, we tell them about the energy envelope that they wake up with every day, and we want them to prioritize where they are going to spend that energy envelope. Focus and decide on which activities need to be done that particular day. So each day the energy envelope is different, and which activities can be postponed to avoid crashing. Positioning means modifying activities to make them easier to perform, and planning the day or week to avoid overexertion, finding those energy windows. And a lot of these 4 Ps that we call are accomplished with the help of physical therapists. Avoiding high intensity aerobic and graded exercise, because that can make symptoms worse and hinder improvements. We encourage them to use interval or time-based activity. We ask them to maintain diaries and remain active for the amount of time, the particular amount of time right under that crash level. We advise them to wear a pedometer to make, keep a track of their average steps in a day, and monitor heart rate. This is very important. So patients will often tell us that, I do this much and then I crash. So we want to determine the maximum heart rate they can tolerate without triggering or exacerbating symptoms, and then avoid in their daily life exceeding that heart rate, except for only short periods. Often it is 120. So pacing includes maintaining a diary. We do review that diary with patients and see if they are gradually increasing the exertion levels for maybe 30 minutes to 31 minutes, or 31 minutes to 32 minutes. and brainstorming techniques with patients to adjust that activity. So for example, if they are getting brain fog or cognitive sort of fatigue after, let's say 30 minutes or 25 minutes of reading, then we want them to back off a little bit. And this can vary from day to day, this can vary from month to month, just as their condition changes. What have we learned from long COVID treatment? No two people have the same symptoms. There is no single treatment yet. We do have many effective strategies in place, they work. And COVID-19 lights everything on fire. It is like a lighter fluid. There are many associated social stressors and consequences of COVID. But again, coming to the bottom line is patients feel relieved when they find a doctor who does not dismiss their symptoms, who actually understands and accepts this entity, and the fact that multidisciplinary clinics and treatment is essential to manage these patients. A few mitigating strategies or avoiding strategies, including vaccination, treating acute infections with Paxlovid if appropriate. And then there is this little blurb that I want to make for metformin. There was a study in a multicentric trial published in Lancet, which said that giving metformin in the acute phase can cut down long COVID rate. And this is, again, I haven't done it myself, but I just wanted to put it out there because there is a study. Vaccination, of course, we know reduces long COVID incidence. Unvaccinated patients can be as high as 10 to 30%, and vaccinated, it cuts down to 10 to 12%. So also I want to highlight that subsequent COVID infections, acute COVID infections, will set patients back, and they will, from their baseline, they will set back and again have to work towards improving their symptoms. So any infection is a setback. So what is the path forward? I want to highlight the United States committee hearing where the proposed clinical trials, the emphasis on defining phenotypes, developing diagnostic and surrogate biomarkers, and equitable access to clinical trials was made. There was also a pitch to establish the NIH Center for Infection-Associated Chronic Conditions. We want to expand clinical care by expanding more long COVID care networks and establishing guidelines and supporting programs, especially for underserved communities. We should not be practicing in silos. That is something that's a takeaway message. There are several sites, long COVID sites that are functioning, and we do want to come together and practice together for the benefit of for our primary care physicians especially. This is Bernie Sanders' moonshot legislative proposal, where he proposes $1 billion in mandatory funding per year for 10 years and create a centralized coordinating agency. I just wanted to briefly highlight what is being done in this area. And long COVID care networks. So across the nation, we have several sites, and this data is from the Atlanta site from my dear friend Tiffany Walker. And what they discovered is that the ICD-9 code, the post-COVID condition, which is UO 9.9, was captured in 0.1% of the primary care patients. On the other side, the prevalence of long COVID is 7% in the population. So you see this disparity. So what we need to do is to increase awareness amongst primary care physicians that there is this entity. This slide highlights some of the ARC long COVID care, the AHRQ grantees, and you will see that the University of Washington is one of them. There are 12 sites. This slide highlights the percentage of adults who have ever experienced long COVID, and the dark green ones are where the maximum number of patients were seen. And I just wanted to highlight in the previous slide that the AHRQ is the Agency of Health, Research and Equity, and their goal is to improve access to equitable care. This highlights long COVID care sites, including rehab sites, NIH recover sites, and specialty clinics. So what is the path forward? The long COVID network expansion and decentralizing long COVID care is what we really hope to accomplish. So in an effort to decentralize long COVID care, we want to come out of the silos. There are several focus groups that I want to highlight. One is our own long COVID national ACP focus group. I chair that group. I will talk about it in a little bit. I invite you to please come to our meetings. We invite experts to talk about different aspects of long COVID care, and it is extremely insightful and educational, and I learn a lot. So we need to map long COVID care providers, link networks, expand access and ensure geographical coverage, establish a common mission with guiding principles, and develop evidence-based guidelines. Long COVID is complex and challenging, and we cannot manage it without the help of primary care physicians. We do recognize the constraints that primary care physicians have, and one of the bigger ones is paperwork, the disability paperwork. And I myself have been a victim to that, and I really feel that there needs to be more guidelines for primary care physicians who by default fill out this disability paperwork. We are developing guidelines at the University of Washington to make things easier for primary care physicians. We are also spending a lot of our time and effort on raising awareness and educating PCPs about long COVID. So these are just patient-reported outcome measures that I wanted to highlight, but I want to go to the next slide first. That long COVID primary care partnership opportunities, which are in phases, phase 1, 2, and 3, that are highlighted by AAPM&R. And this slide talks about developing, about how we can work further. We can provide patient-reported outcome-specific measures, needs assessment, consultative support. And here I want to make a pitch for the University of Washington. We have developed e-consults now that are available to the University of Washington physicians. We hope to expand it to non-UW physicians as well. In addition, we have office hours where which are manned by, of course, our specialists, and we talk to providers about long COVID management. Telementoring, we are providing a lot of telementoring opportunities. We are partnering with the Department of Health in their program Power of Providers, and we have a lot of webinars. We have the National ACP Long COVID Group as one of the telementoring opportunities, and then I also co-chair the AHRQ Telementoring ECHO work group, which is a national work group. We talk in phase 2, we propose and we want to provide shared note templates, epic dot phrases, and culturally competent patient educational materials. We are developing these patient educational materials at the University of Washington. It's been a long time happening, but there are so many changes and we are trying to revamp those materials, but they will be available to you guys shortly. There is also a disability guide coming up, which will help primary care physicians in disability paperwork. And in the phase 3, we propose evidence-based guidelines, modular management protocols, of course, disability guides and AI-driven long COVID tools. These are already being used in the Recover arena. We hope that we can harness those AI tools where the AI can be used to screen patients and answer some of the questionnaires. I want to here highlight an important new project that University of Washington Long COVID Clinic is undertaking, which is the development of a mini fellowship program. We are developing a long COVID mini fellowship, and hopefully that will be available to primary care physicians soon. I want to go back to the previous slide now, which is a slide highlighting patient-reported outcome measures that I talked about in the previous one. It is one of the phase 1 options, which includes COMPASS for POTS, the DSQ-PEM questionnaire for MECFS, and PROMISE, which is used for neurocognitive symptoms. We used these questionnaires on a trigger-based management options in our clinic. The next slide highlights some of the resources that you guys can use, and again, I encourage you to take a picture, or the slides are available on the on the app. But this highlights some of the things that we participate in, including the ECHO, including the Job Accommodation Network, through which we often consult, and the AAPM&R guidelines. Additional opportunities to get involved. Here is our long COVID focus group, the National ACP Long COVID Focus Group. I invite you to please attend it. It's a great resource for you guys. We are building it for you guys. We want feedback from you on how we can improve it further. You can email me. My email address is listed, and I can guide you on how we can, how you can join in. Also, my wonderful colleague Doug Hayes has put the link to the Long COVID Interest Group Google form in the shared resources, and you can sign up. These are some of the accommodation resources and telementoring resources. And in the last 1 minute, I want to talk about infection-associated chronic conditions, on how that is the umbrella organization. This has been recognized by the national academies. I want to circle back to it because infection-associated chronic conditions are neglected diseases. They have not received the attention they deserve, and because we have not been taught much in medical school about them. NASM, in the NASM meeting last year, they focused on developing a common research agenda in IACCs, because there is so much overlap amongst these IACCs, and especially long COVID. We have established the American Academy of Infection-Associated Chronic Conditions, and the impetus behind this was to develop one entity focused on coordinating research, developing resource materials, educational materials, but also curriculum for medical school students, for residents. The mission is advancing education, advocating for research, enhancing clinical care, and promoting equity in the management of IACCs. And the stakeholders here are myself, Tiffany Walker from Emory, Andrew Shamis from the Ohio State University, Hector Bonilla from Stanford, and Lisa McCorkle, who is a patient advocate. So not only will we provide resources, but we also want to provide opportunities for professional development, and this is the path forward for us. I want to make the last statement about long COVID clinical podcasts, which are now available to primary care physicians. They are through Curbsiders, and again, that link will be available on the shared resources. Thank you very much, and I hope that I was able to share some perspective. I will share my resources, my references here, and then I will give it up to the next speaker. Thank you very much.